Thank you for the introduction. Let me just check. So I'm going to talk on stereotactic radiotherapy, or Oraya therapy, for treatment-naive patient with neovascular age-related macular degeneration. These are my financial disclosures. I was asked to give this talk approximately 6 months ago. I audited my data after 6 months, and then, having agreed to give this talk, I said that I needed to maintain my professional integrity and be given the freedom to present what I wished to present. I knew that my data would be analysed, and I didn't want to come along and have a company say, just read our slides and stand at the front. So I have been given total freedom in what I present. Because of my rather poor PowerPoint skills, I have asked the company to rearrange them so they look a bit more professional. But I have, as I say, give my own results. I would say to you in the audience, when you look at this data and how things are, you cannot truly reflect what your own practice is like unless you audit your own data. We have a lot of impressions of how things are, and unless you truly look at your results, you are not quite clear. I looked at these results most recently within the last 4 weeks. That was rather nerve-wracking for Oraya as a company, because they kept asking me, what are your results? And I said, I do not know yet because I have not looked at them. We can be affected by the last patient we saw. If they responded well to something, we're encouraged, and if they appeared not to, we're discouraged. What I present here today is that Oraya therapy results in superior vision in an environment of probable undertreatment, while at the same time reducing the injection burden. Why do I make that statement? When I look at real-world data and the electronic medical record results, which are in peer-reviewed publications, and the Luminous data, in which I am the UK chief investigator, it appears that in real-world data, we cannot achieve the visual acuity improvement that is found in CAT, IVAN trials, and the pivotal trials. And it appears to be that this may be related due to under-injections. I present here data on the first Oraya treatment was given on the 21st of May 2014. I've given 193 treatments to date. And I report here on the first 25 patients to reach 12 months from their first Lucentis injection, and the first 58 patients who reached 6 months since their first Lucentis injection. In our unit, we have an electronic patient record. I have included data here on every patient. I would lack integrity if I came here and said, these are my results, but I excluded the following patients because I really felt I shouldn't have treated them. I present every patient and every bit of data. There is no data that is lost. If I present data at 6 and 12 months, you may say, Chris, that all looks very good, but you had no comparator. Because we've had an electronic patient record for more than 5 years, I asked my IT guys to go back to April 2013 until March 2014 and give me the hospital code of all the new wet age-related macular degeneration patients we started to treat. That gave me a list of 236 patients that we started treatment on in that year. Our unit has all its images on an IT system. I went through every patient hospital code, looked at the image, and made a decision whether I would offer them Oraya therapy had they presented to me. Having gone through that 236, I deemed that 45 of them were perfect criteria. I didn't want debatable cases because I thought if I'm going to use that as a comparator group, I had to be true to myself and also to the patients that we treat. So I believe the comparator group is from the same unit. They were managed and treated in the same way on a PRN basis. And there were 45 patients. I then went into their hospital record to look at how they were treated and what happened to them. And of the 45, 4 did not reach 1 year of follow-up for various reasons, so I excluded those. So who are we treating in Sheffield? We are treating new patients who have had a fluorescein angiogram, which can show the lesion to either be an occult, minimally classic, predominantly classic or RAP. I did not include polyps. The patient had a colour photograph of their fundus, an OCT, and as I say, the fluorescein showed an active lesion. The protocol was for the patients to undergo 1 Lucentis injection. They had Oraya therapy within 14 days of the first injection, and they were mandated to have 2 more injections. These patients do not sit in a special Chris Brand clinic. They are treated the same as all the other NHS patients. And because they're on an electronic record, I don't lose what's happened to them. They're not sitting there under my care. My colleagues and their team could have treated them. In our unit, the AMD patients are under the care of a service rather than an individual. And as I said, they were treated on a PRN basis. Now, we've seen this responder definition before, that there has to be significant subretinal fluid. I believe that significant subretinal fluid is a surrogate marker of disease activity. And if you're treating patients in the review phase, you need that. I did not use the OCT change because I had a fluorescein angiogram that showed me I was dealing with an active lesion. So who did I treat? I treated patients whose choroidal neovascular membrane was in a 4 millimeter diameter area based on the fovea. Some of you may say, but the lesion or the hemorrhage or the leakage may have gone beyond 4 millimeters. Yes, and they received treatment. The membrane had to be within 4 millimeters. The overall size of the lesion could be much larger. So I just want to make that point clear to you. And there had to be no or minimal fibrosis. Now, here is the comparator data. As one would expect in this group, there is the mean age is what one would expect. As you look across, you've got the comparator data on the left, and then the two Oraya groups, 6 months and 12 months. The gender is what would expect. The only perhaps thing to look at there is that in the comparator group, there was an increased percentage of RAPs. It was interesting. I then looked at the RAP outcomes in the Oraya group, and they performed particularly well. So here is the visual acuity results. If you take the pink-coloured first, the comparator group, some of you may say, did you choose the right group? The change in visual acuity in 6 months and 12 months does not look very good. Whenever you look at visual acuity change in a trial of AMD, what you need to know is the baseline visual acuity. In that pink group, the baseline visual acuity in that comparator group, 40% had a visual acuity of better than 6/12. They would not have been able to be entered in the pivotal trials, and that is far higher than lots of other trials. And we know from AMD trials that the visual outcome is dependent upon your baseline visual acuity. So although you may look at those patients and think, Chris, that wasn't a very good comparator, they are early patients treated early with good vision. So those results are not too bad. What then makes it significant is if you look at the dashed line of the Oraya group, they also had a 40% greater than 6/12 baseline visual acuity. And at 6 months, 60% of them are greater than 6/12. So there's 4 lines of improvement. And if you then look at the 12-month group, there's a similar improvement. 30% of these patients at baseline had a visual acuity of better than 6/12. And that improvement continued out to 12 months and is statistically significant. These are the results presented in perhaps a more familiar fashion. The box at the bottom shows those patients that improved by more than 15 letters. The box at the top, those that lost 15 letters, and the intermediate group. If you look at the two Oraya groups, the percentages are almost the same. If you look at the comparator group, more patients lost more than 15 letters and fewer patients gained 15 letters. Here at 12 months is the average number of injections that were required. In the Oraya group, 4.6 injections were required, whereas in the comparator group, 5.63 injections were required. Because we mandated for 3 injections, what the pie charts below show is that in the Oraya group, 60% of patients over the following 10 months, because patients were treated at baseline months 1 and 2, 60% only needed 0 or 1 injection, compared to 34% in the control. 1/3 in each group needed between 2 and 3 injections, and 8% in the Oraya group needed more than 4 injections, but 29% in the comparator group. So here's the visual acuity and injection comparisons. So if we look at the Oraya therapy, at 12 months, there's an increase of 5 letters with 4.6 injections. I've mentioned the UK comparator group. They had 5.6 injections and lost 0.3. If you look at the UK EMR 1-year data, that is in peer-reviewed publications, they improved by 2 letters and had 5.8 injections. There is in that data of the EMR, if you take the first eye, their baseline visual acuity, 20% were better than 6/12, and the second eye, 50%. So that's kind of like a hodgepodge, but that is their headline result. And look at IVAN, 5.5 letter improvement following 7 injections. The safety. There is no radiation-related microvascular changes noted. We wouldn't perhaps expect them at 12 months. Some of the patients that we treated that developed disease in the second eye underwent a fluorescein angiogram within the 12 months of follow-up, and there was no evidence of microvascular changes in the treated eye. So, in summary, Oraya therapy was well tolerated by the patients. Oraya therapy offers over standard anti-VEGF monotherapy controls in Sheffield superior visual outcomes and fewer injections. 1/3 of patients did not require more injections at 12-month review following 3 mandated injections at Oraya therapy, and at 6 months, 60% did not require more injections. The other thing to note is in the 6-month follow-up group, there were 2 patients who, as I said, were mandated to have 3 injections. One patient had bilateral disease, had an injection in one eye, and when I looked at the results at the first review, it put both eyes dry, and for some reason they didn't get their second injection. That patient has only had 1 injection out to 6 months, and another one had 2 injections and for some reason didn't get their third. This is not a trial, as I said, so they didn't get any more injections. So if we're going to move from PRN to treat and extend, which lots of us are doing, I put the question out there is, should we give 1 dose of anti-VEGF and Oraya therapy and immediately start treat and extend? Or do we, under perhaps our present regime, commit our patients to 7 injections if you give a loading dose of 3, or if you give fixed doses, 7 injections? I think in the future I perhaps need to look at the OCT anatomical correlates, analyse the data for the 12-month post-period loading, and continue to track safety and efficacy. Another aside, when I audited my retrospective data of patients that were either 2.5 years to 1.5 years post-treatment, just under 10% were no longer alive. So when we're looking at safety that might go out to 10 years in this group of patients, I just popped that there. Thank you very much.